Welcome to this session on the new Kidney Disease Improving Global Outcomes, or KDIGO Clinical Practice Guideline for Diabetes and Chronic Kidney Disease. I'm Ian Boer, Professor of Medicine at the University of Washington in Seattle, Washington, United States, and co-chair of the new guideline, along with Dr. Peter Rossing, one of today's speakers. We're very excited to present this new guideline, which is the KDIGO first guideline on this topic, which comes at a very opportune time with exciting developments in diabetes and chronic kidney disease care. I'd like to very briefly introduce the new guideline by summarizing its goals and scope. The writing group for the guideline aimed to generate a document that was based on strong evidence, reviewed rigorously by an expert review team, and a guideline that was clinically useful. The scope included topics for which high-quality evidence was available, focusing on randomized controlled trials, and addressed both types 1 and types 2 diabetes and all stages of kidney disease, including patients treated with dialysis and kidney transplantation. The guideline writing group included experts with diverse expertise. Notably, it also included 2 patients present from the beginning of the guideline process. Without further ado, I'd like to introduce 2 members of the writing group who will summarize key aspects of its content. And that is Dr. Peter Rossing from the Steno Diabetes Clinic and co-chair of the guideline, and Tami Sadusky, a patient representative from Seattle in the United States. I'd like to encourage all members and viewers of this session to provide questions through the EASD platform question site, and we'll have about 5 minutes at the end of the session to review those questions with the speakers. So without further ado, let's start with the presentations.
Welcome to this presentation on management of diabetes and chronic kidney disease and the KDIGO guidelines which has just appeared on this topic. My name is Peter Rossing. I'm Head of Complications Research at Steno Diabetes Center Copenhagen in Denmark and Professor at the University of Copenhagen, also in Denmark. These are my disclosures. And the outline for this presentation is going to be first to talk about comprehensive care in diabetes and CKD, then talk about glycemic monitoring and targets in patients with diabetes and CKD, talk about lifestyle interventions in patients with diabetes and CKD, then the anti-hyperglycemic management of patients with diabetes and CKD, and finally talk about approaches to organization and management of people with this condition. But very important for this guideline is that we put people with diabetes in the center of care, and that's also why I'm very pleased that Tami, that will speak after me, was part of our working group when developing these guidelines and will give her perspective on this topic. When we talk about comprehensive care of people with diabetes and CKD, it's about considering that it's not just about glucose or not just about the kidney. Comprehensive care means that there's a foundation therapy that everybody needs to have, which is about management of lifestyle factors, exercise, smoking, controlling cardiovascular risk factors such as blood pressure, lipids, in addition to, of course, glucose. And then in people with diabetes and CKD, blocking the renin-angiotensin system has been key for several decades. And now, in addition, treating with SLT2 inhibitors with type 2 diabetes patients with chronic kidney disease has become a key, which is also something I'm going to address a little later. And then in some patients, we add antiplatelet therapy if cardiovascular risk is particularly high. So the point is that it's not just about glucose, but a lot of risk factors we need to address in people with diabetes and chronic kidney disease. Secondly, people with diabetes also need to be looked out for or screened for other complications than renal complications, meaning that looking out for eye disease, foot complications, neuropathy, and so on, is also an important part of the comprehensive care of people with diabetes and chronic kidney disease. Now, coming to glycemic monitoring and setting targets for glycemia in people with diabetes and chronic kidney disease, we have recommended to use hemoglobin A1C also in people with diabetes and chronic kidney disease. There has been debate that several factors affect hemoglobin A1C and the association with mean glucose levels in people with impaired renal function, particularly factors like anemia is common. But data show that down to eGFR of 30, hemoglobin A1C works very well, and that's why we have recommended this. For the daily monitoring of glucose, self-monitoring of blood glucose or even continuous glucose monitoring is recommended in the guideline. This is particularly useful if you are being treated or the patient is being treated with glucose-lowering agents that are causing a risk for hypoglycemia, such as insulin, sulfonylurea, whereas it's less important in people treated with agents like DPP4 inhibitors, GLP-1 receptor agonists, SLT2 inhibitors, and metformin, where there's no risk for hypoglycemia. For the glycemic target in people with diabetes and chronic kidney disease, it's very much as in people without chronic kidney disease but with diabetes. That means we suggest to have an individualized target. In some, it should be a hemoglobin A1C down to 6.5%, and in others, it might be a target of 8%. And there are different risk factors, such as the risk for hypoglycemia, comorbidities like cardiovascular disease, life expectancy, which are important when you set a target for an individual person. But in patients with chronic kidney disease and diabetes, it's also important to consider the stage of chronic kidney disease, because with advancing chronic kidney disease, the risk for hypoglycemia increases, and therefore the aggressiveness in glucose monitoring or targets will be less compared to in earlier stages of chronic kidney disease. Now, moving from the targets, how to monitor glucose, and into lifestyle factors, then of course nutrition is very important in people with diabetes and chronic kidney disease as in other people with diabetes. And here it's important to realize that sometimes guidance directed towards chronic kidney disease patients are different from guidance to diabetes. But we have recommended that in patients with diabetes and chronic kidney disease, they should have a diet which is individualized according to the preferences of the patient. But otherwise, it should be a diet high in vegetables, fruits, whole grains, fibers, plant-based proteins, and there should be less of processed meat, refined carbohydrates, and sweetened beverages. It's also important that people with chronic kidney disease in general have a lower physical activity level compared to other people for many different reasons. And they should be encouraged to have an active lifestyle to the extent possible. So we recommend, as in general recommendations, 150 minutes of physical exercise per week. And we recommend to avoid sedentary behavior. We also recommend that if people are obese, that means a BMI above 30, then weight loss should be considered. Now, moving to the anti-glycemic therapies in people with diabetes and chronic kidney disease, that's where a lot has happened in recent years. Still, lifestyle intervention is the foundational therapy. And as in other recommendations, for instance by here EASD ADA, we recommend starting with metformin in type 2 diabetes. But what is new is that any patient with chronic kidney disease and type 2 diabetes should be considered for SLT2 inhibitor therapy as well. That's because we have seen fantastic outcome data showing prevention of progression of chronic kidney disease with these treatments. And therefore, if you have a GFR above 30, you should initiate an SLT2 inhibitor regardless of the level of hemoglobin A1C. When I said start with metformin, that also needs to be tailored to the level of GFR as indicated in our figure. And if SGLT2 inhibition and metformin is not sufficient to control the level of glycemic control, then we prefer adding a GLP-1 receptor agonist. But otherwise, there are different options such as DPP4 inhibitors, sulfonylurea, insulin, TZDs, and alpha-glucosidase inhibitors, which can be applied stepwise in order to reach a glycemic target, but also taking individual needs and considerations into perspective when choosing your therapy. For the SGLT2 inhibitor intervention, it's important to consider and be aware that this is recommended in any patient with type 2 diabetes and chronic kidney disease and a GFR above 30. That's based on studies like Credence, and it's important that when you start this therapy, you consider, are you at risk for hypoglycemia or not because of other therapy? So if you are, for instance, above target, you add an SGLT2 inhibitor, and when I say above target, that's for hemoglobin A1c. If you are at target, then you need to consider if you are on other medications which could induce hypoglycemia, such as sulfonylurea or insulin, and then consider if you should switch that therapy to an SGLT2 inhibitor to avoid hypoglycemia. But that's something which has to be individualized in the patient, but usually consider that SGLT2 inhibitors should be added to these patients, and that they don't reduce glucose very much if you have a GFR below 45 or so, but it's not for glucose lowering they are given. They are given for their cardiorenal protection in these patients. Further advice if metformin and an SGLT2 inhibitor is not sufficient to reach the hemoglobin A1c target can be devised from this figure. Here we have tried in the center to show some preferences, comorbidities, or other characteristics which can influence choice of treatment. And then in the inner green zone, we have indicated preferred treatment, and in the outer red zone, indicated therapies which are less suitable, either, for instance, because of risk of hypoglycemia, or if you consider you would like to avoid injections, then you should avoid insulin, and so forth. Now, going to the final part of the guideline, which is about organization of care and how to organize things, but also how to advise people, then a structured educational program is key for educating people with diabetes and chronic kidney disease. Such a program should enable patients to know about their disease, to be skillful for self-management and self-motivation. This program should include information about vascular risk factors, increase engagement with medication, lifestyle factors, and also reduce the risk to prevent diabetes-related complications and improve emotional well-being in people with diabetes and chronic kidney disease. It's important that this program is structured and that it's regularly evaluated in the sense that otherwise it will not be efficient. That has been demonstrated as also outlined in our guideline. And finally, it's important how you organize care. That means care is a team-based approach where doctors, nurses, dietitians, and other healthcare providers work together. And also, when I say doctors and nurses, it's about endocrinologists, but also nephrologists and often cardiologists need to be involved. It's also important that we organize care in a structured and systematic way where we record in, for instance, electronic health records, how we are achieving goals or not achieving goals if we are doing screening as mandated, because that's the only way that we can achieve an informed and activated patient and also a proactive and multidisciplinary team working together to improve outcome for people. So overall, to summarize this, the new guideline provide recommendations on comprehensive care, glycemic monitoring and targets, lifestyle interventions, anti-hyperglycemic therapies, and approaches to management of patients. Focus is on patient-centered decision-making and support, which is emphasized throughout the guideline. Diet and exercise remain foundation of care, and hemoglobin A1c is the standard method for glycemic monitoring, and targets should be individualized. We have also mentioned that continuous glucose monitoring can be useful in some situations. For type 2 diabetes, the base drug therapy is, in addition to metformin, including an SGLT2 inhibitor. Also, GLP-1 receptor agonists are recommended as a preferred agent next to metformin and SGLT2 if this is not sufficient to reach target. I'd like then to extend great thanks and acknowledgements to the whole working group that developed this guideline. I had the pleasure to co-chair together with Ian de Boer, and otherwise I will not list the people, but I will just stress that this was a multinational, multidisciplinary working group with people from the whole world, including dietitians, physicians, patients with diabetes. And it was thanks to all these people that we managed to develop this guideline. So thank you to all of them. And hereby, thank you for listening to my presentation.
Hello, I'm Tami Sadusky. I'm a member of the KDIGO Guideline Working Group on Diabetes and CKD, and I'm also a patient, bringing the patient perspective to the KDIGO prepared guidelines. When I was asked to participate on the KDIGO Guideline Working Group, my first thought was, well, what a fabulous idea to incorporate the voice of a patient into this group. It is rare to have the opportunity to really be part of a group developing guidelines about your own care. The patient voice brings a new and different perspective to the table. What I found working with this group is that facts and research are the key to the guideline development, which, of course, is how it should be. But then bringing the real life of a patient into the conversation helps validate things even more. You can tell a patient 10 times to take their medication, to eat this, don't eat that, to exercise more, but they may become so overwhelmed and are not able to handle everything, and then all of the great recommendations, well, they become not very useful. Guilt is a huge issue for patients with diabetes and CKD, and really understanding how to help them manage all they need to do is so very valuable. One thing that I found valuable as a participant in this working group was the experience of creating guidelines for people all over the world. I quickly learned that every culture is different, and the needs of a person with diabetes and CKD in one country can be profoundly different from other countries. And although there are similarities, of course, the guidelines had to take into consideration many components, including culture, cost, the availability of some of the medications, and even family dynamics. So I'd like to tell you a little bit about myself, living with diabetes and CKD, and why I was actually asked to be a participant in this working group. I was diagnosed with type 1 diabetes at the age of 13, which in general is a difficult time for most people entering puberty. Then adding diabetes on top of that, and you have a whole new life you never really asked for and you're not so sure you really want. I began with 1 insulin shot a day, NPH, was told not to eat sugar, to follow a low-carb diet, higher in fat and protein, come in for a glucose test about every month, but otherwise, life as normal. My siblings were off to college by this time, so my parents and I made our way through this diabetes maze, trying not to make too many mistakes along the way. But my family lived in a very small town in Alaska with a population of about 1,800 with one doctor. Although I was diagnosed after about 10 days of exhibiting symptoms, the management plan was somewhat limited, but I know it was based on what was known in that area at the time. Today, I feel very strongly that one of the most important things for individuals is to be tested and diagnosed early and to begin a care plan where both the patient and the physician and possibly other healthcare providers are working together as a team. Education is so important at this stage, and often the patient doesn't even know what to ask. It is not true that what you don't know can't hurt you. Quite the opposite. So when I was diagnosed, we were given the basics on how to manage my diabetes, but discussions about how to ensure that I stayed healthy for my entire life and what things may happen if I did not, those were not really discussed very much. Not until those things began to happen. As I mentioned, I started on 1 insulin shot a day, which over the next 20 years increased to 4 shots a day. I was just getting ready to start on an insulin pump. A1C was not available at that time or just getting started, so monitoring my glucose level was a blood draw at the hospital every month. If the level was around 100, I was told, "You're doing good. Go home, do the same thing." But if it was 400, 500, 600, I was either put in the hospital or I was asked, "Why are you not doing so good? What are you doing wrong?" Guilty again that I was messing up, and I was not even sure why. So family lifestyle was not really a consideration when I had diabetes, at least at the beginning. We were given the diabetes rules, which focused on insulin, eating, and some exercise, but how to really make it all work together well so that I would feel good every day, so that I was mentally sharp, and especially so that I could avoid future complications, well, those were not high on the list. As I later learned, all of those things must work together for your body to work well when you have diabetes. For 20 years, I lived with type 1 diabetes. I lived with it. I battled it. My parents battled it. We hoped for the best, and we prepared for the worst. First, I developed retinopathy, having cataract surgery at the age of 21, over 20 laser surgeries to cauterize the leaky blood vessels in my eyes, partial loss of vision in one eye, and complete loss of my peripheral vision. And then neuropathy arrived kind of about the same time. Hands and feet were constantly numb and cold with very little circulation. Then gastroparesis was next. I would go out for a walk, wake up on the sidewalk surrounded by paramedics who I came to know quite well, or on the floor of a shopping mall or a bank. So by this time, the insulin I was injecting every day was not assimilating with the food I was eating, nor the exercise I was participating in. And when the insulin kicked in, but the food didn't, down I went. And finally, I was told my kidneys were failing. Otherwise, life moved along. I attended college, I received my master's degree, and I worked full time. Then my life changed. So after receiving news that my kidneys were failing and that I would probably not live through another blackout, I was put on the waiting list for a pancreas and kidney transplant. 2 months later, what I call life phase 2 began, and it looked pretty good. The last time I took my own glucose level or used insulin was the day before my transplant. My father brought me 3 candy bars on day 1 post-transplant, even though I was hooked up to numerous tubes and couldn't eat, but he was just so excited for me. Time moved quickly. 9 days in the hospital. 6 months later, I began working full-time. I began walking half marathons. I began ballroom dancing. I learned how to golf. I began traveling internationally, and I lived. I really lived life. But I knew that the immunosuppressive medications I would take daily for the rest of my life may have long-term effects. People often tell me, "You don't look like you've had a transplant," which always confuses me. Should I look tired and unwell? Haggard? No, I should look healthy. And I really credit this to focusing on 3 key elements post-transplant. My diet, and although with a pancreas transplant I no longer had diabetes, I could eat sugar-laden cupcakes and my favorite black jelly beans. I eat them in moderation. Exercise, which I amped up as I recovered, really helped me not only to enjoy my new life, but ensured I was doing everything possible to take care of my new organs and keep them with me as long as possible. And finally, making sure that taking my transplant medications is a top priority every single day. So unlike after my diabetes diagnosis, I had a full healthcare team to work with post-transplant. It made all the difference, and it still does today. Although I parted ways with my wonderful endocrinologist as my primary physician, I stayed in touch, and I began working with my new nephrologist and other healthcare providers to monitor my new organs and to stay on top of any transplant issues that may come up. So for 18 years, my pancreas and kidney ran smoothly as I packed as much into my new life as possible. Sadly, after years of reoccurring UTIs, it was decided a new kidney might be better than spending quite as much time in the ICU as I was for a couple of years. In 2011, my second kidney transplant was a success and is with me today. So this year, 2020, marks 27 years with my new pancreas and 9 years with my second kidney. My life changed after my transplant. I worked at the University of Washington full-time for 22 years, leading to pursue my goal of what I call giving back to the diabetes and kidney and transplant community that has played such a huge role in my life. As all of you know, diabetes is a serious disease that impacts your entire life. So is chronic kidney disease, and so is an organ transplant. We all must deal with what we have been given, and we do that in different ways. As a person with diabetes and CKD, I was susceptible to many other medical issues. And as a transplant recipient, I am more susceptible to things like cancer, osteoporosis, and I know there is a chance that I may lose one or both of these organs and eventually have diabetes or CKD once again. I do not focus on these things, but they do concern me. My belief is that moderation is the key to a healthy life. I am well versed in things that will help me stay healthy, like eating well, exercising, taking my transplant medications, and just doing common sense things, like washing my hands on a regular basis. And I am hopeful that one day in the future, we will be talking about diabetes and CKD in the past tense. Thank you.
Thank you, Peter and Tami, for your presentations, and thank you for the questions rolling in the question box. We have about 5 minutes to address those. I'll take the first one, which is, when will the KDIGO guidelines on diabetes and CKD be available? So those are anticipated to come out in print in Kidney International and Kidney International supplements next month, October 2020, and should be available online within a week of today. So this is very timely. This is a sneak preview. You'll be able to get the full details, including an executive summary, very soon. Additional questions, Peter, the first couple I think are for you. One, are SGLT2 inhibitors recommended in type 1 diabetes with chronic kidney disease?
Thank you. No, it's not. In most countries, it's not allowed, but in some countries, like in Europe, it's allowed to treat type 1 diabetes with SGLT2 inhibitors, but there are no data on the renal outcome, so therefore it's not in our guideline. There are some post hoc analysis suggesting that there might be a benefit, but we definitely need more studies before we can recommend this.
And the second question is, there is some new evidence that empagliflozin in particular may be usable down to 20 mils per minute. Do we recommend using SGLT2 inhibitors at lower levels of GFR than 30?
Well, evidence is evolving, and we have based our guideline on particularly the Credence study, which was the only dedicated renal study when we made the guideline, saying 30 in GFR should be the threshold. On the other hand, DAPA-CKD includes patients down to 25. And as mentioned in the question, there are some data going even lower, and in Credence, they continued until dialysis, which seems to be safe. So it's important to remember that the threshold for GFR was initially based on the notion that there was no glucose lowering effect, and the drugs were indicated initially for glucose lowering, whereas for kidney and cardiovascular protection, this might not be relevant.
Thanks, Peter. And one more question for you here about, in practice, metformin is also limited by eGFR. Is it possible that SGLT2 inhibitors could become first line before metformin? How do you respond to that question?
Well, thank you. The reason for having metformin first is that has been foundational therapy in all trials so far, and therefore we recommend to start with that. Of course, there might become new data or come new data saying that SGLT2 inhibitors could be first line, and that has also been suggested, for instance, by European cardiologists and others, to say that why start on metformin? But we have done so because that was how the studies were conducted so far.
Tami, a question for you. With your unique perspective now of seeing the need for comprehensive care as put forward in this guideline, and all that patients have to deal with, and the importance of self-management and patient engagement. What do you see from the patient perspective are the keys to implementing this comprehensive approach to patient-centered care?
I think the most important thing is really lending your voice to what's going on in your healthcare institution, and letting it be known that you want to be part of the healthcare decision-making team, and working with your physicians and the dietitians, the endocrinologists, your nephrologists, your cardiologist, everybody who plays a part in your healthcare team, that you'd like to participate. You want to understand what's going on. You are your own best advocate, and you know best, you know the most about yourself. So sharing that with your healthcare team can help them help you.
Thank you very much. There are more good questions I see here. Hopefully some of those will be answered when the guideline comes out soon. We have to stop now to be respectful of time, but I'd like to thank Peter Rossing and Tami Sadusky for your presentations today. Thank the EASD for allowing us to present a sneak preview of these guidelines, and of course the whole writing group of the guidelines, and the KDIGO staff and evidence review team for their contributions to making these. And I hope you all will look for these guidelines as they are published soon. Thank you very much for attending this session.